Welcome to Introduction to Pediatric Cardiology. My name is Joseph Block. I'm a pediatric cardiologist at Children's Hospital of Wisconsin, and we are affiliated with the Medical College of Wisconsin. Today, we're going to go through a general overview of congenital heart disease. I'm briefly going to talk about some history, then discuss what fetal circulation looks like, and then go into more of congenital heart lesions that we see. This includes acyanotic heart disease as well as cyanotic heart disease. And I've listed some of the lesions that we will talk about and go into more specifics. An overview of congenital heart disease, otherwise known as CHD. First, it affects, and I think one of the most important things for you to know is that it is rampant in our community, and it is the most common congenital heart or congenital defect there is. It affects about 1% of the population, or about 40,000 births per year in the United States. 25% of the babies with congenital heart disease have critical congenital heart disease. This is typically defined as those infants that need surgery or another procedure in the first year of life. Currently, there is an estimated 2 million infants, children, and adolescents and adults living with congenital heart disease in the United States. About 1 million of that is children, and 1.4 million of that is in US and adults. So really, no matter where you guys practice, you will run into patients with congenital heart disease. It is a huge growing number in the adult population as we do better to help these children survive, and it is likely that you'll see in no matter where you practice. Just a little back history on the surgical history of congenital heart disease. It was first done by Rain, was the first operation that was really noted on the heart, and that was done in 1896, and that was where a patient had been stabbed in an altercation. Really, it didn't become more of a routine thing until the 1950s, but Gross operated on a 7-year-old girl with a patent ductus arteriosus in 1938. We'll talk about a patent ductus arteriosus later on. It's a relatively minor procedure nowadays, but as I said, in 1938, this was a very risky procedure, and he actually completed this when his chief of surgery was out of town. Gross was eventually fired because he did this procedure, but it was eventually rehired. Gibbon developed the first heart-lung machine in 1953, and he closed an atrial septal defect. And then Lillehei in Minnesota was kind of our pioneer of open heart surgery and performed the first ventricular septal defect closure in 1952. And since that time, our field of pediatric cardiology and pediatric cardiothoracic surgery has grown by leaps and bounds. And we'll discuss some of those surgeries going forward. So once again, the main thing we're going to talk about today is this congenital heart disease. We're going to go through normal cardiac anatomy and then talk about some lesions. As I said, we're going to divide those in acyanotic lesions and cyanotic lesions. So let's first go through cardiac anatomy. As you can see, this is a picture depicting a normal heart, a cartoon of a normal heart. So this is the superior vena cava, and blood flow comes from the superior vena cava, from your head and upper body, from your inferior vena cava, which is depicted right here, and drains into the right atrium. It then crosses the tricuspid valve into the right ventricle, and then the heart squeezes and blood flow gets pumped out the pulmonary valve into the main pulmonary artery and into the branch pulmonary arteries, which then head out to the lungs. Picks up the oxygen that we're breathing, and the oxygenated blood comes back through the pulmonary veins into the left atrium, down across the mitral valve. The heart squeezes again, and the left ventricle pumps blood flow out the aortic valve to the aorta, up to the brachiocephalic vessels that supply blood flow to your arms and head, and then down to your legs and organs to supply the oxygen that we need to survive. So that is just kind of a quick summary. I added some of the abbreviations that I might have listed later in the lecture just so you can reference. But every time your heart beats, all of this is happening. So this is really the basis of what we look at, and going forward, this is kind of the main figure I want you guys to think about when we have the lesions that we're going to talk about going forward, and how that is different, and how blood flow flows differently in those lesions. Is headed out to the brachiocephalic vessels. And the rest of the, only about 10% of the total output from that LV crosses the aortic isthmus, is basically right prior to where that ductus enters. So really, that the main point of that is just stating that the right ventricle supplies most of your cardiac output needed for your organ development and survival. So let's jump into congenital heart lesions. I divided them, and you can divide them in many different ways, but I think one of the easiest ways to do that is acyanotic versus cyanotic. So cyanosis is just a physical exam finding of patients that have low oxygen saturations. So when I say acyanotic, I mean that they have very normal saturations. And when I talk about cyanotic lesions, this means that they are desaturated and have mixing of, or they have, deoxygenated blood being sent out to their body. So first, we're going to talk about acyanotic heart lesions, and you can divide those further into physiologic consequences of the two. So we're going to go through acyanotic lesions with left to right shunt and acyanotic lesions with outflow tract obstruction. And we'll talk about a few examples of each. So those with left to right shunts include, so this is blood flow going from the left side over to the right side. This includes ventricular septal defects, otherwise known as VSDs, atrial septal defects, known as atrial septal defects, patent ductus arteriosus, or PDA, and atrioventricular septal defects, also known as AV canals, or AVSD. So a left to right shunt exists when blood flows from the left atrium, left ventricle, or aorta across to the right atrium, right ventricle, or pulmonary artery. So this results in fully oxygenated blood that has already been to the lungs, recirculating back to the lungs. So you can see how this, the heart starts doing inefficient work over time. So normal, the volume of lungs should equal the volume to the body. And a lot of times we express this in the ratio of QP to QS, where QP is the volume to the lungs, or pulmonary flow, and QS is the volume to the body, or systemic flow. So the QP to QS ratio expresses the magnitude of that left to right shunt. So if you have a large left to right shunt, like in the setting of a ventricular septal defect, a large one, then you will have a higher QP, more pulmonary blood flow than systemic blood flow. So in patients, as I just said, with large left to right shunt, the QP is greater than the QS. So as I mentioned, ventricular septal defects are one of the most common forms of congenital heart disease. As I said, it is the most common besides bicuspid aortic valve. It's 20% of congenital heart disease. The prevalence is about 2 to 4 per 1,000 live births. It's very commonly associated with chromosomal abnormalities, including trisomy 13, 18, and 21. The causes are likely multifactorial with the interaction of genetics and environment. So as you can see from this picture, it's kind of similar to the cartoon we talked about with the normal anatomy. You can see the arrangements of the atria and ventricle are very normal, and their outflows to the pulmonary artery and aorta are normal. But you can see this gap right here, the opening between the ventricles, and this is the ventricular septal defect. So not only does, when the LV contracts, not only does blood flow go out to the body, it also, that oxygenated blood, which is depicted by the red blood mixing with that blue blood, which is now purple, so that oxygenated blood going back out to the lungs. So really the left ventricle starts doing inefficient work. There's many ways to talk about VSDs, and their location can vary. This is an older cartoon, but basically just depicts the multiple different regions that VSDs can exist in that septum. And really that can have effects on their surgical planning and outcomes long term. So really we classify them according to the relationship to anatomic landmarks on the right side of the septum. So we have the membranous, this small section right up here. And actually this is the aorta here, and you can't see, but the aortic valve sits right here. So that's why being close to that aortic valve does have some long-term potential complications from that. The outlet of the infundibular septum is depicted with the O there. The trabecular or muscular septum here. Inlet septum, which is the inlet is just where, is basically just talking about where the blood flow is coming into the right ventricle and left ventricle. So it's back down near those tricuspid and mitral valves. I put up this slide because basically it just depicts those four regions again, the membranous, the outlet, the inlet, and the trabecular and muscular. But I just wanted to give you guys a sense that you'll see many different names for these locations, and sometimes that can be very confusing. We don't have to go through all of them, but just want you to, you can see with outlet ventricular septal defects, there's where it's 8 different names that can really describe that. And this can be very confusing and seems like very semantics to many outside, but this really helps us describe these lesions as best we can for the surgeons. So the physiology of VSDs, it can result in 3 major complications. Congestive heart failure, one of those is congestive heart failure, abbreviated with CHF, secondary to a large volume left to right shunt. This can result in pulmonary overcirculation, or that increased pulmonary blood flow, so they can get edema in their lungs. Another complication is they can get left ventricular dilation or dysfunction as a late consequence. Typically, we see this with our children, not so much on the dysfunction side of it, but the left atria and left ventricle dilate over time as it deals with that chronic volume overload, and that can be an indication that the patient needs surgery. A really late major complication is pulmonary hypertension with the eventual reversal of shunt to a right to left shunt. This is often called an Eisenmenger syndrome. This is really a late complication. Really, we should not see that in the Western medicine or as long as they have had follow-up. The pulmonary hypertension results from this chronic left to right shunt, which then results in pulmonary arterial changes in the blood vessels and results in increased pressures, which then over very long periods of time results in a right to left shunt, and then they can become cyanotic. We also look at the magnitude of the VSD, and the shunt, that magnitude is really determined by 2 factors, both the VSD size and the pulmonary vascular resistance. So even if you had a very large VSD, if you had high pressures on the right side, you might not have a significant left to right shunt because the pressures on the right are typically lower than the left. And so if those pressures on the right are higher, then there can be an equalization of pressure, and then blood flow won't preferentially go across that hole. So as I said, it should be classified based on size, the right ventricle or pulmonary arterial pressures, the pulmonary arterial, abbreviated here PA, and the volume load. So a small VSD is typically restrictive. So it's so small, there's the blood flow really just kind of squeaks through there, and there's oftentimes normal PA pressures with no volume over there. Basically, summarize a small shunt. It's very restrictive. It's limiting the amount of volume of blood flow going across the hole and out to the PAs. So your left-sided structures are not dealing with a significant volume load of increased blood flow coming back from that VSD. A moderate size defect usually has some restriction, so blood flow is not just freely going across, but the PA pressures are, but it's larger than a small, and the PA pressures are lower than the systemic ventricle. But we do see that over time, the LV and LA dilate because of that significant volume overload. There's two different, and the main one with a large VSC is that it's non-restrictive, so blood flow can freely go left to right with near systemic PA pressures, and we see significant LV and LA overload. And then, as I said previously, this is usually a very late chronic finding, but if you have a large defect with elevated pulmonary vascular resistance or high pressures in the PA or an RV, then you can develop a right to left shunt, otherwise known as Eisenmenger syndrome. VSDs typically present with a loud holosystolic murmur, so between S1 and S2. As I said, the babies can present with congestive heart failure, and typically how that presents in a baby is that they have tachypnea or poor weight gain. They also can have tachycardia and hepatomegaly or enlargement of their liver. Their chest X-ray oftentimes shows cardiomegaly and increased pulmonary vascular markings in moderate to large VSDs, and that's just due to the pulmonary overcirculation. The cardiomegaly is due to the dilation of the left atrium and left ventricle from the significant volume load on the heart. And echo is really the study of choice to identify both the location and. So basically what this is supposed to show is that there's color flow going through, and I think you can very clearly see that there's a defect here. And that blood is flowing. Well, this picture should have shown blood flow going left to right. So VSDs, if they are causing clinical problems, or if that we are seeing a significant left-sided volume overload, they're indicated for surgical closure. And it's generally straightforward and very successful. They can be difficult if there's multiple holes that in the muscular septum, and sometimes that can be difficult to visualize. And sometimes we restrict the amount of pulmonary blood flow by putting a band over the main pulmonary artery to decrease those symptoms. Or we do a double patch technique where we put a patch on both the right and left side of the ventricular septum. Very rarely we do interventional or basically put a plug via catheter to close these defects, but it's definitely been reported. This is not a very routine thing that we do over at Children's, but it is definitely something just to take note of. The other very common acyanotic lesion is an atrial septal defect, or an ASD. It's 6 to 10% of all congenital cardiac anomalies. It is more common in females with a 2 to 1 predominance. It's typically sporadic, but there are definitely some familial cases reported, especially with Holt-Oram syndrome or genetic lesions on NKX 2.5 and GATA4. Not that you guys need to remember those specifically, but I think it's just important to realize that these ASCs can be seen in some familial or hereditary cases. Once again, similar to VSD, we base how we discuss about ASDs based on their size and where in the atrial septum it is located. Secundum defects are basically kind of right. This is a picture, kind of a cross section. Sorry, it's a little bit tough to understand. This is IVC coming up here. This is the SVC coming down. This is the atrial septum. We're kind of looking through the right atrium right now. Through those holes is the left atrium and where the pulmonary veins come in. This white structure here is the tricuspid valve, and the right ventricle is down here. So it's kind of looking from the side into and through. They've cut away the right atrium here to look at that atrial septal wall. And the secundum atrial septal defect is a very common one, basically right in the central location of that. There's the primum ventricular septal defect. This is the typical this is the primum atrial septal defect that is typically seen in AV canals, right down at the base of the heart. We also have superior sinus venosus defect. So this one is sitting right kind of where the SVC enters, or an inferior sinus venosus defect, kind of right where the IVC enters. There's also where the coronary sinus enters, that can also be a defect down there. The physiology of atrial septal defects are kind of twofold. The effects on the lungs, this left to right shunt causes volume overload, and different from the VSD, it causes right-sided dilation because all that volume is now coming over from the left atrium to the right atrium, and so the real right side of the heart is dealing with that increased volume and subsequently causes a compensatory dilation. The tricuspid valve and pulmonary valve can be stretched and become thickened and subsequently incompetent. And it also can have effects on the lungs long term. It can cause chronic volume overload because of the increased volume on that pulmonary vascular bed. And it can also, if it's untreated long term, can cause severe irreversible pulmonary vascular changes and pulmonary hypertension. But once again, that's a pretty late finding. The physiology of atrial septal defects is again determined by the size of the hole, as well as the ventricular compliance, or basically how well the bottom chambers relax and allow for that increased volume. Usually heart failure symptoms are rare just due to the low pressure chambers, and chronic volume overload causes real right heart dilation. These patients can present with maybe a soft systolic murmur or a wide fixed splitting of the second heart sound. So you get a fixed splitting of both the aortic and pulmonary valve as they close. They can present with dyspnea and fatigue sometimes later in life. Oftentimes we can find them too just on routine x-rays. They are found to have cardiomegaly with increased pulmonary vascular markings. Their EKGs oftentimes have evidence of right heart enlargement or dilation. But again, going back, echo is diagnostic of. So these are two echo pictures. Once again, I hope that they play. But just as a reference, this is the right atrium, right ventricle, ventricular septum, left ventricle, left atrium, and right here is the atrial septum, and an ASD is present. Over here too, this is another cross section. So this is the SVC, IVC, and the movie shows it better. And I apologize again for these not playing. But the atrial septal defect is right here. This is the tricuspid valve. This is the right atrium. So that's the SVC and IVC coming into the right atrium. And this is a portion of the left atrium. So you can see, and what this really showed was the blood flow going from left. So the treatment of these, there's really no medical treatment. You can give them definitely medical treatment, just as in VSDs, to help with their heart failure symptoms. But really, they need to be large defects, and moderate defects oftentimes need to be closed with elective repair. But oftentimes, and this can oftentimes be deferred till they're like 2 to 4 years of life. Small to moderate ASDs, on the other hand, may close spontaneously. So we oftentimes watch these kids very closely to ensure that they're not having any clinical problems with this, and we give them every chance that they can close on their own. Early repair is often indicated for infants and children who have significant right heart dilation or that they have developed heart failure symptoms. But the long-standing volume overload of the right atrium and ventricle can cause irreversible changes if surgery is not done. And this can result, because of the atrial tissue becoming more dilated over time, it can result in arrhythmias and even premature death long-term into adulthood. So there's two different forms of really treating or managing these patients, or closing it, excuse me. One is surgery, and one is as a day procedure in our cardiac catheterization lab. Surgery is usually done with going through the breastbone and their sternum, and you can be as simple as using some sutures to close a relatively small structure, or if they need to use a patch material that they sew in to close that left to right shunt. These patients usually do really well and can be even out of the hospital in 3 days. The other form, which obviously does not require open heart surgery, is being done in the cardiac catheterization lab. This is a device closure and can be a day procedure that they come in the morning and are home by dinner time. This is an example of two cartoons of two of the devices that we have. The one on the left is called an Amplatzer device, and the one on the right is a Helix device. This again is the right atrium, and we've tunneled a catheter up into their heart through their femoral artery and vein up to their right atrium, and then can put that plug and take it out of the catheter and deploy that to close the hole. So this is the atrial septum here, left atrium. You can see the pulmonary veins coming in here. You do need, and most of these, and we have newer technology that is less reliable on this, but you can see why this this device needs tissue here for it to grip and to attach to. Again, the helical device is just a different form and option that we have that once it's deployed, it should bring both of these, the device that's on the left atrial side and the device that's on the right atrial side, will cinch that together and close the hole that's defined right here. In untreated ASD, usually have a benign course. They can close up to the ages of 8 years of age. They have very uncommonly, so those patients without symptoms will likely not have symptoms until later in life, but more commonly after the age of 40. So that's why even if they are asymptomatic for their longevity and need to avoid arrhythmias long term, that will close these early in life if it's not likely that they'll. The prognosis, if untreated, like I said, they can long-term into adulthood. There's been evidence of premature death due to progressive right ventricular dilation and right heart failure. They can have recurrent pneumonias, pulmonary hypertension, and arrhythmias such as aflutter and atrial fibrillation. The prognosis, though, is excellent for those who have undergone surgical closure or device closure with normal survival. Another acyanotic common lesion is AV septal defects or AV canals. This is about 4 to 5% of all congenital heart disease, very common in trisomy 21. And the features of AV canal defects that they have their atrioventricular valves or their tricuspid and mitral valve leaflets insert at the same level at the crux of the heart. And they have both a ventricular septal defect as well as an atrial septal defect. These are just some cartoons showing the normal anatomy here. Whereas a complete AV canal, this is a side view. So this is the atrial septum here. This is the ventricular septum. This is some of the AV valve or the tricuspid mitral valve tissue. And you can see that there's a hole here as well as a hole here. This is a cross-section first of a normal heart. So this is the normal AV valves here. And you can see with a complete AV canal that the tricuspid and mitral valves are basically one valve. And so when we repair this, we really take this and septate the heart and close both the atrial septal defect as well as the ventricular septal defect, but also have to repair these AV valves. This is just another summary showing the different forms of AV septal defects or AV canals. And once again, I suspect that my echo pictures will not be playing. We'll try it again. No, it doesn't seem to be working. Sorry about that. But really what this shows is there's a large hole between the top chambers of the heart too, and as you play, you can see that there's a smaller ventricular septal defect here and one common this just kind of depicts the common AV valve, and once again, I apologize that these are not playing. We continue to follow them as they can have um, problems with their both their tricuspid valve as well as their mitral valve. Let's move on to patent ductus arteriosus. This is also a very common lesion that we see. The incidence and physiology that are such that there's about 2% of this occurs in about 2% of all congenital heart defects. It is a normal fetal structure that usually, so it's something that we all need in utero, but it usually closes spontaneously within the first 72 hours after birth. There is unlikely spontaneous closure after 3 months of age. And typically we will follow them, and I follow them up until a year to give them to close, because I have seen some later closure of spontaneously of these PDAs. So this is, again, a couple echo pictures that demonstrate a PDA. And just some of the physiology, if the ductus arteriosus remains open in a newborn, that pulmonary vascular resistance usually drops in the first days, hours of life. And so the pressure in the aorta becomes significantly higher than the pressure in the pulmonary artery, and blood flows from the aorta to the pulmonary arteries through the PDA. This results in a left to right shunt. So instead of going across the septum of the heart as in ASD or VSD, this is a left to right shunt from the aorta to the pulmonary artery. So it sends that oxygenated blood flow back to the lungs instead of out to the body, and it can result again in heart failure. These patients have a different type murmur. It's a more continuous murmur, almost machine-like, that you hear in the left upper sternal border, and maybe not heard until that pulmonary vascular resistance drops and blood flow really starts to go through that PDA. If there is a significant left or right shunt, then the patients might have bounding pulses and wide pulse pressure, and they can develop congestive heart failure and failure to thrive. Sorry, I abbreviated those. Congestive heart failure and failure to thrive. If it persists into childhood, pulmonary vascular disease can develop. So that's why we usually give them time for them to close spontaneously. But if we're seeing significant symptoms or that it hasn't closed by a year of life, we're really talking about closing them to help with their longevity, the patient's longevity. Their chest X-ray might show cardiomegaly and increased pulmonary vascular markings, and their EKG might show left ventricular hypertrophy or LVH. Their echo is definitely the diagnostic choice to identify the PDA and estimate the amount of volume shunt. And as with VSDs, this will result in significant left heart dilation. So, as I said, if PDA remains patent or causes heart failure, closure would be indicated. Sometimes we can try medical closure with such medications like indomethacin, and that can help promote this closure. Otherwise, surgical ligation can be done via left thoracotomy, so kind of the left back that the surgeon will go in, so very minimal um, exposure, so it's not an open heart through the sternum type surgery. But oftentimes, in most patients, we can do these, and we're doing these at smaller and smaller size babies, that we can do a coil or device closure. So basically, that's what this picture shows here, is basically a vascular plug. So this is the main pulmonary artery branching to the pulmonary arteries here. This is the aorta with the brachiocephalic vessels. And here's the ductus arteriosus, the blood vessel that connects both the main pulmonary artery to the aorta. And you can see that we can insert a plug here in a similar fashion that how we talked about ASTs to close that. Now, just shifting gears a little bit to acyanotic lesions with outflow tract obstruction. Those include coarctation of the aorta, aortic stenosis, and pulmonary stenosis. Some genetic anomalies such as Turner syndrome, Facey syndrome, and Noonan-Williams syndrome. We definitely, and this is, we classify coarctation in pediatric cardiology based on where that narrowing is. So once again, this is the main pulmonary artery with the branches, the aorta, the brachiocephalic vessels, and then here the narrowing can be either right at where the ductus, sorry, number 3 is where the ductus inserts. So it's what we call juxoductal, or basically right at the level where that ductus inserts. Preductal, which is depicted here by B, and postductal. Coarctation of the aorta can be associated with many different cardiac anomalies, including bicuspid aortic valve, PDA, VSD, aortic arch hypoplasia, aortic stenosis, whether that's valvar, subvalvar, or supravalvar. So basically, a lot of these are left-sided lesions, including mitral valve abnormalities. There's definitely two different ways that these patients can present. Oftentimes early in life, they can present once their PDA closes. So like in those first 2 weeks of life, they can present with poor feeding just because they're not getting blood flow to their gut, and so they can have significant irritability with that. They can result in tachypnea, increased work of breathing because they're developing acidosis. They can be lethargic and tachycardic and really present in shock. Their physical exam findings, they can have a difference between their upper extremity and lower extremity blood pressures, and they can have diminished lower extremity oxygen saturations. That's typically due to the ductal flow going right to left. So the PDA is supplying the blood flow to their lower extremities. So that's why they might have decreased oxygen saturations. They may have a systolic murmur, and they might have diminished pulses or absent pulses in their. A late presentation, you always have to be thinking about coarctation, are those patients, those young children or teenagers that are presenting with hypertension. Or a new murmur. It's not unusual if that these can be ways that they present. It's definitely more common that we catch this in a neonate, but it's always on my differential for a new patient coming in with hypertension. These symptoms, these patients might complain about chest pain or symptoms with exercise. Basically, they have increased oxygen demand to their extremities during exercise, and so if the heart cannot supply that because of that obstruction, then they might develop symptoms. They might have frequent headaches from the high blood pressure in their head vessels. They might have fatigue, colder extremities, and very rarely they might have life-threatening intracranial hemorrhage. If this is found very late, they might have premature coronary artery disease because of that high pressure in the preductal region. So the pathophysiology usually, so this again is showing the arch. This is a MRI reconstruction. You can see the brachiocephalic vessels coming off here, and there's like a kink. This is the descending aorta. You can see that there's a real narrowing right here. So there's obstruction of flow that results in increased left ventricular afterloads, or basically increased pressure beyond the left ventricle. This causes increased wall stress on the left ventricle, which results in thickening or hypertrophy of that left ventricle. And then long term, this can result in congestive heart failure, and they can develop shock, acidosis. Echo, again, is a diagnostic study of choice, especially for the younger patients. We can see the aortic arch very well. It provides an accurate, non-invasive assessment of the anatomy and gives us really a pressure gradient to estimate how severe this is. It also is really important by echo to look for other intracardiac lesions. As we talked about, coarctation can be associated with many other intracardiac lesions, such as bicuspid aortic valve. Really, it's the disadvantage is we can't see the collateral flow that oftentimes these patients have post-ductally, and that's where CT and MRI can be very helpful. This is a picture just showing, so here again is the ascending aorta. The brachiocephalic vessels are taking off here, and as the blood flow goes on the descending, there's this kind of kink or really narrowing right here. And this is depicted by the flow. You can see so blue flow coming down away from the Doppler and really accelerating right here. There's a very small opening to allow blood flow down to the lower. This is an MRI showing pictures of, and you can see right here, this is once again, ascending aorta, brachiocephalic vessels, descending aorta down to the belly. This is a cross section, so the sternum's here. Here's the spine. And you can see that there's definitely a narrowing or kink right there. And this is a 3D reconstruction where you can see that narrowing right here as well. Sometimes and this is rarely, but sometimes we do have to go to the cardiac catheterization lab. And in older children, we can actually place a stent to balloon that narrowing open. But this again they've injected contrast into the ascending aorta right here, brachiocephalic vessels. One common feature is that those brachiocephalic vessels are widely spaced. As you can see here, that's just an unusual pattern that is really important for me when I'm looking at these that might signify a coarctation. And here you can see that narrowing here too. So the treatment, really, in a baby, you can open up that patent ductus arteriosus with prostaglandins and help correct their acidosis and support their left ventricle. But repair where you cut out that narrowing and then bring it back together. This is a description of an end-to-end anastomosis here. As I said, sometimes we can do this in the cath lab via stenting. So now we're going to take a break and go on to cyanotic congenital heart disease. So once again, these are babies that often have desaturation or their oxygen levels are low. One of the most common and the most common cyanotic congenital heart disease is tetralogy of Fallot or TOF. There's 4 components. One is there's a right ventricular outflow tract obstruction. So the right ventricle squeezes, and there's oftentimes hypertrophy of the muscle right below the level of the valve. Oftentimes the valve is small too, so there's an obstruction of blood flow getting out to the lungs. There's a large VSD that's depicted here. There's aortic override, which basically just means that the aorta sits over the ventricular septum here and so it's definitely getting some blood flow from the right ventricle that goes out that way. You can see how there's the purple mixing of blood flow here that's depicted in the cartoon. And the last one is that it can develop right ventricular hypertrophy. So the tetralogy of this lesion is there's a right ventricle outflow tract obstruction, there's a VSD, there's aortic override, and then there's right ventricular hypertrophy. As I said, it's the 5th most common heart defect and the most common cyanotic heart defect, and it's oftentimes associated with syndromes and genetic anomalies. The clinical features, these patients can have minimal to severe desaturation, depending on how much blood flow is obstructed when it goes out, and really the degree of right to left shunting. Their X-ray is often classically described as a boot-shaped heart. So the apex of their heart is kind of upturned here, and if you use your imagination, maybe it looks like a boot. They also can develop blue or hypercyanotic spells. This results when the patient has severe obstruction or no obstruction of blood flow getting out to your lungs, and so it's all right to left shunting. So you can imagine how this can be very severe. If you're not getting any blood flow out to your lungs, then you can't get the oxygen you need to supply blood or supply oxygen to the rest of your body. So it's a severe emergency. Sometimes starting factors can be agitation, dehydration, hypovolemia, and hypoxia, um, and um, and it can result in a significant hypercyanemic. So to treat this, we oftentimes give them oxygen to decrease their pulmonary vascular resistance and to promote blood flow going out to their lungs. We oftentimes will try putting knees to the chest position or squatting. This increases their systemic vascular resistance. This promotes left to right shunting and blood flow out to the lungs. We can try to give them increased preload by giving them, if we have an IV, giving them volume. Oftentimes, a thing that helps significantly is giving them some sedation and decreases their work of breathing. And we correct their acidosis. Sometimes there's reports of beta blockers being helpful to improve their volume preload, as well as decreasing the infundibular narrowing. Alpha agonists to increase their systemic vascular resistance has also been used. But really, once patients start having hypercyanotic spells, they really need surgical intervention. These are echo pictures showing the left ventricle. Here's the aorta. This is the ventricular septum here, and you can see how that aorta sits and overrides the ventricular septum. And there's that large VSD. This picture is a color picture showing the blood flow exiting the right ventricle, and really you can start to see the color changes right at the level of the valve. That really depicts that there's an increased speed of the blood flow through there, suggesting stenosis or right ventricular outflow tract obstruction. To repair this, initial repair is favored, but sometimes we have to do palliative shunting or stenting to support their pulmonary circulation. But typically, the surgery is done by closing the VSD and opening that right ventricular outflow tract, whether that's with resection of that subpulmonary valve muscle or increasing the size of the main pulmonary artery by a transannular patch, by increasing the diameter and allowing blood flow to more freely go out to the lungs, and then it comes back. So you can understand, or I hope you can understand, how these patients can get into severe trouble if there's no levels of mixing. Then oxygenated blood can't get out to the body, and these patients can, if it's not found, can ultimately, if nothing is done, will die very quickly after birth if there's no levels of mixing. So this is a significant emergency to know about these kids when they're born. It is seen in about 5 to 7% of all congenital heart disease. It's the 10th most common, and it is the second most common cyanotic heart lesion right after tetralogy flow. There's a male predominance, and the incidence is about 20 to 30 per 100,000. Associated anomalies include that they oftentimes have a ventricular septal defect. They can have tricuspid valve anomalies. They can have left ventricular outflow tract anomalies. Coarctation can be seen, and sometimes they can have extracardiac anomalies as well. So the physiology of transposition of the great arteries, as I said, there must be the systemic venous blood flow, or basically the blood flow that's from the left ventricle, must get to the pulmonary circulation to be oxygenated. So the systemic blood flow coming from that goes out to the aorta has to get to the pulmonary vasculature to get oxygenation and then get pumped back out. So you have to have these levels of mixing. Again, the pulmonary venous blood must pass into the systemic circulation to supply the oxygen to the tissues. And so this shunting must occur there's 3 levels that it can occur at the atrial septal defect here, at the ventricular septal defect or again at the PDA. So this is just a way to think about it from a circuit standpoint. From a normal anatomy, the right atrium receives blood flow, which then goes down the right ventricle to the pulmonary artery, to the lungs, comes back from the lungs with the oxygen to the left atrium, to the left ventricle, which then pumps it out to the aorta into the body, delivers all the oxygen, and then through the veins comes back to the right atrium. And so we have a series circulation here. With transposition, you have two parallel circuits that don't, if they don't have these levels of mixing, that don't interact. So the body brings the blood flow back to the right atrium, right out to the right ventricle, out to the aorta, and back out to the body without the oxygen that it needs. Whereas the lungs, it's just recycling that oxygenated blood flow. So you have to have these levels of mixing at the atrial septal defect, VSD, or PDA to allow these patients to do well. That will increase their pulmonary venous return. Their LA pressure will be greater than their right atrial pressure. And their PDA flows from their aorta to their pulmonary, increasing pulmonary venous return. An atrial level shunt is key. If there's adequate communication, then the increased LA pressure that we just talked about would result in a left to right shunt, allowing mixing and the balancing of volumes in the circulations. It also significant elevation in the left atrial pressure would not occur, and cyanosis may not be as apparent. If there's just a normal PFO or very small shunt, PFO stands for patent foramen then an increased left atrial pressure would tend to close the PFO, and this would further increase the left atrial pressure and result in more significant cyanosis. We oftentimes try to keep the PDA open, as patency may be beneficial, as it can provide a channel for mixing. But ductal patency alone may result in significant steal from the systemic circulation. And these patients may be at risk for further complications. The initial management is, first we want to stabilize these patients to allow for adequate cardiac and pulmonary function and to get oxygenated blood where it needs to go. We can give them prostaglandins to keep their PDA open, and perform a balloon atrial septotomy to open up their atrial. Historically, what we did with these patients is we would baffle the blood flow from the SVC and IVC over to the left ventricle that then pumps it out to the pulmonary arteries. And we would baffle the pulmonary veins over to the right ventricle that oxygenated blood would then go out to the body. The problem with this is that it can cause right ventricular dysfunction because the right ventricle is not meant to be the main pumping chamber, so that can be a late complication. They can also develop arrhythmias because there's a lot of suture lines in their atrium, as well as these baffles can be obstructed over time. Now we do what's called the arterial switch operation, where we basically cut above the level of both the main pulmonary artery and the aorta and switch them and tie them into the appropriate ventricle. So the aorta and pulmonary artery are divided. We have to excise the coronary arteries and reattach them to the neo-aorta, and as we correct this lesion. The last one that we're going to talk about is a hypoplastic left heart syndrome. This cartoon depicts here, again, this is the SVC coming down, IVC coming up into the right atrium. This is the tricuspid valve. Heart squeezes out to the pulmonary artery, comes back with that oxygenated blood to the left atrium, and here you can see there's oftentimes can be mitral atresia or near, this picture, the cartoon doesn't even show a mitral valve. It shows a very hypoplastic left ventricle and a very small aortic valve and ascending aorta. And so these patients are really dependent on that PDA initially to provide systemic circulation. So this is what we call our single ventricle, and it's a single right ventricle. Hypoplastic left heart syndrome is seen in 0.163 cases per 1,000 live births, or 16 per 100,000 live births. It represents 7% of all congenital heart disease. There is a male predominance, and 95% will die within the first 6 months of life if left untreated. There's things that we can do to help these patients to prevent that mortality. There's strong evidence supporting a genetic etiology, but this is something we are continuing to look at, including looking at environmental factors that might predispose a fetus to develop this. So once again, there's one ventricle. These patients are cyanotic because there is significant, so the cyanotic blood flow or deoxygenated blood flow is then being sent out to the body. And so that's why they would be desaturated on their pulse oximetry. They have this obligate right to left shunt here that blood flow has to go from the PA to the aorta to supply the body with blood flow. There's oftentimes hypoplasia and atresia of the left heart structures, as we talked about just in that last picture. The left ventricle, mitral valve, and aorta are oftentimes very hypoplastic or very small and incompetent to really support systemic circulation. This is an echo picture showing again. So this is the diminutive left ventricle. This is, if you can imagine, the mitral valve here, left atrium, large right ventricle, and the tricuspid valve. So the real survival right after birth is dependent on patency of that ductus arteriosus. And the right ventricle is supplying both the pulmonary and systemic circulation through the PDA. The coronary and brachiocephalic vessels supplied retrograde through the hypoplastic aortic arch. So the blood flow to the pulmonary arteries or systemic system depends on the resistance of those two regions. And so the major determinant of pulmonary blood flow is the size of the ASD. So if you have a restrictive ASD, that will increase the pressures in the left atrium and increase the pressure into the pulmonary veins and therefore into the lungs. So they have an increased total pulmonary vascular resistance. And this will result in increased pressure into the lungs, and so increased pressure right here into the lungs, and that will promote blood flow going down to the body and less pulmonary blood flow. An unrestrictive defect can result in systemic hypoperfusion. So that would mean that the pulmonary vascular resistance, the pressures here on the lungs drop. And so blood flow would preferentially want to go that way and not out to the body and result in systemic hypoperfusion. At birth, the patient's the PDA is widely patent. Their pulmonary vascular resistance is high. So the blood flow is pretty well balanced. Get older, their PDA begins to close and their pulmonary vascular resistance decreases. This results in poor blood flow to their body, decreased coronary blood flow, and increased pulmonary blood flow. So they have plenty of blood flow getting to the lungs, but they can develop in acidosis, shock, and ultimately death if nothing is done. Treatment strategies is typically these patients go down a staged palliation or oftentimes can be listed for transplant. In some rare cases, parents may choose palliative care. So initially, as I said, we would start prostaglandins. We would try to open up that atrial septum. Here, the right ventricle has to pump both out to the body as well as pump through a shunt to the lungs. So the right ventricle would fail long-term over time. So we offload that work that it has to do, the bidirectional Glen and subsequently the Fontan, where the Glen is taking the SVC and attaching that directly to the pulmonary arteries. So the right ventricle does not have to pump to the pulmonary arteries. It can just pump out to the systemic circulation. And then the Fontan, the hole, so the IVC to the pulmonary arteries. So now both the SVC and IVC are passively draining to the pulmonary arteries.
the Fontan procedure. As I said, it creates a uniform caliber connection with minimal turns to connect both the vena cava with the pulmonary arteries. Sometimes we can put a fenestration here to, if the pressures build up in the lungs, if they have lung disease, or it can have, it's basically like a pop-off valve into the atria. Um, And so this is called the fenestration of the Fontan. This is an intentional defect to allow for right to left shunting. It can give you more LV preload or RV preload and cardiac output if you have elevated PVR. So as I said, so in summary, that was a long talk. I hope you guys learned something, and it is always tough to do virtually this way. But please reach out to me if you guys have any questions or concerns. But the main thing I want you guys to get a little taste of what we do at Children's Hospital at the Herma Heart Institute, and know that this is extremely common lesions that you guys will see, and no matter what you do, if you're involved in the medical field. There's it's seen in 1 in 100 people walking around, and it is a huge growing population in the adult world. So you will see these patients. Thank you so much, and I hope this was beneficial.